Hello, everybody, and welcome to this episode of AABIP podcast. I'm your host. My name is Jasleen Panu. I'm an interventional pulmonologist and assistant professor of medicine at Ohio State University Medical Center. I have the pleasure today of having with me Dr. Fawad Chaudry, who is the assistant professor of medicine and director of IP at University of Oklahoma. Welcome, Fawad.
Thank you, Justine. Appreciate it.
So, we are going to speak on a very interesting topic today, use of endoscopic ultrasound by interventional pulmonologists. So, Fawad, as a bronchoscopist and IP, we also use endoscopic ultrasound sometimes in our practice. Where do you see the utility of this device in our practice, and why do you think it's important?
So, Justin, again, as you said, very, very important topic to touch base on. And I thank you again for the opportunity to talk on that. In my practice, primarily whenever I'm doing mediastinal staging for lung cancer, or if I'm doing biopsy for non-lung malignancies or a metastatic disease. And in fact, on some of the lung nodules and masses, which are proximal to esophagus or in the posterior mediastinum. These are all the various places where I do use endoscopic ultrasound in addition to endobronchial ultrasound. And I think regarding your second question, why? So I would like to kind of go over on that based on the evidence as well as rationale. So when we talk about evidence, so I think first I would say that if we go back to the guidelines, there have been a shift in the guidelines, right? From 2007, where mediastinoscopy was one of the suggestions. 2013, chest guidelines recommended the needle-based technique over surgical staging. And then moving forward, NCCN and revised ESTS guidelines suggested, needle-based technique as well as the first invasive, staging technique. And then finally, we have these combined ERS, ESTS, and ESG guidelines that recommend a combined approach. So really, we've evolved from surgical to a needle-based technique to combined approach, which means endoscopic and endobronchial ultrasound within the needle-based technique, which is getting more and more acceptance. So I did review the literature, and I would say that there are about 48 studies on this topic. And out of those 48 studies, that is in the last decade and a half, I would say about 12 are reporting on combined EUS-EUS. And there are 2 meta-analyses as well. And most of these are suggesting that there is improved sensitivity of combined approach and mostly increased accuracy as well, combined approach as opposed to either EBUS or EUS alone. And if I am not mistaken, I think 6 studies are also talking about the EUS-B, which is using our EBUS scope as opposed to the EUS linear, right, which is the GS scope in the combined staging. So I'm not going to go into details of studies, but a couple good studies that I would like to mention. Just a couple points. One of the studies in 2014 by Lieberman and colleagues in Montreal, which is also my parent institution, showed and they did the technique there is doing EUS-EBUS combined in all staging patients, followed by in that study mediastinoscopy. And they did show the sensitivity and negative predictive value was significantly improved in a combined approach. In fact, with a combined EBUS-EUS, there was N2, N3, and M1 disease in 24 patients that they detected where mediastinoscopy was negative. Because the stations you can reach with EBUS-EUS really exposes the whole mediastinum, which either approach alone does not, and mediastinoscopy, of course, it does not. Oki and colleagues in 2014, meta-analysis 2016, there is a very recent SCORE study in ERS in 2019 that have shown the same effect in the sensitivity with EUS-B, which is, as mentioned, for us as interventional pulmonologists, it's we can it's a lesser learning curve to use EBUS scope in the esophagus as opposed to the big GI scope or EUS linear.
Yeah.
So I think that's where, as mentioned, there is significant literature on this topic. Now, why do we think, as a rationale, that combined has a higher sensitivity than either approach alone? Mm-hmm. So if we look at the mediastinum, right, with EBUS, we can do the upper and lower paratracheals, subcarinal, as well as the hilar lymph nodes. Mm-hmm. With the caveat that if 4L is small, if we are doing the normal staging, it becomes sometimes difficult to get that. So EUS is in studies as well as in my personal experience, 4L almost always, even if it is 5 millimeter, you can hit it with EUS, as opposed to when you're going through trachea with the cartilage. Mm-hmm. Also on the 7 station in the studies, as well as my personal experience, whenever I'm having a hard time getting on the rows, but when esophagus approach is used, we get the diagnosis because there is no intervening cartilage. Mm-hmm. So this is those stations that we can reach through EBUS. But what about other? Mm-hmm. Level 8 and level 9 are beyond the reach of EBUS. Mm-hmm. So these are both approachable very easily through EUS, and we routinely do them as long as they're enlarged. Mm-hmm. Then we can get to celiac axis lymph node as well as left adrenal through EUS, and that defines a metastatic disease that is not doable by EBUS. Mm-hmm. Finally, level 5 and 6, right, which are basically periodic and subaortic lymph nodes.
Yeah.
They are reachable through EUS, but not by EBUS. Mm-hmm. And those lymph nodes, of course, they are done in very, very special circumstances when there's upper lobe tumor and when a surgical VATS is not an option in the initial diagnostic realm. You can do 5 and 6 primarily with EUS. Mm-hmm. And there have been some reports of transvascular biopsy of 5 and 6. Mm-hmm. But I think the largest series that came was from Montreal, and I was part of the paper. I and my colleague did it with Dr. Lieberman. Mm-hmm. It's a study which is which is the largest in the literature of 100 patients with transaortic and trans-PA or transvascular biopsies. But that is, again, it's a whole different topic. Bottom line is you can approach those stations if needed. So primarily, if we are looking into 5 and 6, 8 and 9, lymph node stations, plus small 4L, mm-hmm. celiac axis, left adrenal. Mm-hmm. This is all cannot be done through EBUS, but we combine both. We have the whole mediastinum that we can stage, plus we can get to the metastatic disease of adrenal gland, left adrenal. Mm-hmm. So I think that's where we can look into studies that sensitivity is higher with a combined approach.
Well, thank you for summarizing it so eloquently, Fawad. And you mentioned very rightly that not a lot of us use the endoscopic scope to do this, but use of the EBUS, the endobronchial ultrasound scope, the linear scope in the esophagus is probably more common. And a lot of the listeners may relate to. What are some specific indications and contraindications of using that technique, or any tips on that technique that you have?
Yeah, so you're right. I think there is definitely significant literature that is showing the benefit of combined approach using EUS-B, which is EBUS scope in the esophagus. So I would say all the indications that I mentioned that we use for EBUS, for example, I think very important again for complete mediastinal staging for lung cancer. We can use the EBUS scope or EUS-B for paraesophageal lung masses or lung nodules, especially those that are in tricky spots, for example, in front of the vertebral column or behind the heart. Those can be approached. Of course, for non-malignant disease, for example, sarcoidosis, you can still use the EUS as a complementary tool to EBUS as well. So really, all the indications that we use for EBUS can be used for EUS-B as well, with add-on if we have to get level 8 and 9 as I described previously. Level 5 and 6, I would say that's more EUS linear. That's probably not doable with EUS-B. But level 8 and 9, as well as many reports have described left adrenal and celiac axis approach to EUS-B as well. So I think all the indications that we use for EUS linear, for the most part, we can use EUS-B, sparing aside level 5 and 6, and in some cases, small adrenal gland. And I'll go over, why adrenal gland is sometimes difficult with EUS-B, but for the most part can be done as well.
Perfect. Is there any contraindications for that? Do you, watch out if the patient has cirrhosis or some chance there may be variceal enlargement or any contraindications to this?
Very good question, and I think you hit it right there. Of course, with any history of significant peptic ulcer disease or variceal bleed in the past, we should not do it now. Provided if it is a high mediastinal and there is no other way, and if the proceduralist has the expertise to do gastroscopy as well, then you can do that and make sure there is, you're above the level of those varices and all that. You can still do the biopsy. But in general, right, if you're not going to do the endoscopy, then it's better to stay away in those situations. Other than that, I think couple of things that I would like to point out. The most important thing is the operator's expertise, right? So that is important because perforation is one of the rare complications that can happen. More so described with EUS linear, because that's a huge scope, and if it's not introduced appropriately, then that can lead to that. Other than these things, I think the regular contraindications that we have for EBUS as well, like hemodynamic instability, uncontrolled bleeding diathesis, those are the other contraindications.
Perfect. I think that's also useful information for operators who do this, or for those of us who are wanting to start doing this.
Right.
Just briefly on the use of the endoscope for left adrenal biopsy or adrenal biopsy, and it can sometimes also aid in certain lung nodule biopsies. What input would you have on that? I think you had more details you were going to add.
Yeah, so I think any EUS approach, which is either EUS-B, which is our endoscope, or EUS linear, can be used for diagnosing lung nodules. And I'm trained in Montreal, where there was we used to do endoscopy before EUS in all the patients, and we were using EUS linear 90%. But in my practice here at university, because I have fellows that I'm training in the pulmonary critical care, so I'm using 50-50, right? So most of the times I will just do as we discussed as a pulmonologist, EUS-B. If I can get to the lesion, which in most cases I can, the lesions or lung nodules or lung masses which are close to the mediastinum, especially paraesophageal, as I said, in front of the vertebral column, behind heart, those that we cannot access from the trachea, more easily approachable from esophagus. They're right next to esophagus, especially on the left side. They're very, very easily done by EUS-B. And once, especially new interventional pulmonologists who start doing EUS-B, it's such an easy pass without intervening cartilage, so the yield is actually pretty good. And we see much less, mostly, it's not a rule, much less trauma and bleeding, when we do through esophagus. So I think those are the nodules and locations where we will use EUS-B. Regarding left adrenal, so Number one, I think we should of course do a left adrenal whenever it is PET avid or it is above a centimeter, or if it is concerning, right? To stage it appropriately when we are staging for lung cancer. So I almost always use linear EUS because I feel it's easier. I can collapse the stomach and see the adrenal much easier with the linear EUS, because there is you have much more things at your hands with linear EUS. However, I have done big sized few times adrenals with EUS-B as well. And there are definitely reports in the literature as well as papers that are describing, adrenal gland being done by EUS-B. Mm-hmm. So as long as, we have the landmarks, vascular anatomy and landmarks memorized good, or we are expert there, I think it can be done.
Perfect. Thank you, Fawad. Definitely, you have a very unique skill of being able to use both scopes, but also thank you for summarizing the use of EUS-B. It's definitely a skill that can be tapped into, but at the same time, like all of our skills, has to be used with a lot of caution and consideration.
One more thing that I would like to just add. Yes. I think the technique wise, the main learning curve in the EUS is the vascular anatomy. Mm-hmm. And I think once that is learned, then it becomes easy, because all of us as pulmonologists and interventional pulmonologists, intubating an esophagus is not a big deal. Mm-hmm. You can learn it very quickly. But then once the vascular anatomy and the landmarks, then it becomes easy. And a couple things there when we go down with the EUS scope or EUS-B. The way to do is you go down in the stomach all the way from the esophagus to stomach, find the left adrenal, and then find the liver, and then retract the scope with a circling, like a circling motion. Mm-hmm. And then some of the landmarks that we need to identify are, of course, the IVC and right atrium, and then left ventricle, left atrium. Mm-hmm. And we keep pulling it up with a circular way, and then we identify aorta and PA. Once we have done that, and we have done few of these, you get comfortable with this vascular anatomy and these landmarks I described, then I think EUS becomes much more easier.
Mm-hmm. Absolutely. Thank you for highlighting that. Vascular anatomy, absolutely important on each and on EBUS as well as EUS. Right. I think it's been a very useful and learning chat. I've definitely learned a lot from you. So thank you for giving us your time, and looking forward to chatting again sometime.
Thank you so much, Jasleen, and really appreciate it. And we all are learning from each other.
Yes, definitely. Okay, take care. Thank you.